Okay, welcome to the CRT Review course. This is designed to help you prepare for your CRT Secure exam. And the very first slide, we're going to talk about oxygen therapy, specifically Venturi masks. And Venturi masks are based on Bernoulli's principle. And some of the things that you should know about the Venturi mask that the exam might ask you, one is that when you increase the flow rate, it does not increase the FiO2. It does increase the total flow a little bit, but your FiO2 remains unchanged. The smaller the size of the jet, and the jet is a small hole where the oxygen tubing is connected to, the smaller the size of the jet, the greater the entrainment, and the lower the FiO2. So if you were to look at the jet size, let's say a 21% versus a 50%, you'll see that the hole is very tiny, which results in a greater drop in negative pressure, causes more outside air to be entrained, and your FiO2 is less. And that's vice versa for your higher FiO2s. This is a high flow device, and if you're asked to select a appropriate device for somebody who could have COPD and severe CO2 retention, a low percentage Venti mask, 24 to 28% is a good choice, as well as a 1 to 2 liter nasal cannula. Now the next slide is assessment of weaning parameters, and some of the things you should be aware of is that a high minute ventilation or high respiratory rate, or both of these, are poor indicators for weaning. And when I say high minute ventilation, I would say over 20 liters per minute, or a high respiratory rate greater than 30. They are both poor indicators that an individual may be able to breathe on their own. They indicate an increased work of breathing. The next one is the NIF. Of not minus 20 is the benchmark that we typically look for. If they have less than minus 20, minus 15, minus 14, that's usually indicative that their muscle strength is not all that sufficient and they may fail the weaning or the extubation. So 20 is what we're looking for. NIF, by the way, is also known as your maximal inspiratory force, and it is used as a parameter to gauge whether or not whether extubation or weaning will be successful. The last one is the rapid shallow breathing index, and the benchmark for that is less than 100. And the way you determine the rapid shallow breathing index is you take the spontaneous rate divided by the spontaneous tidal volume. In this example, you would have a rate of 32 spontaneous divided by a spontaneous tidal volume of 300, and you have 107. So 107 would be higher than what we're looking for, and so this may be an index that the person may not wean effectively. Okay, the next slide deals with assessment, polycythemia. You should be aware that polycythemia is basically an increase in the red blood cell mass, hemoglobin hematocrit. And one of the things you want to relate polycythemia to, it is a secondary compensatory factor in patients with severe COPD or CO2 retention. In other words, chronic bronchitis. Typically, chronic bronchitis are polycythemic. They also are the ones that appear cyanotic. That's because they typically have more than 5 grams of oxygen dissociated from hemoglobin, and therefore they show the cyanosis. So polycythemia is a compensatory factor associated with chronic bronchitis, COPD, and something you want to look out for. The calculation of your VD-VT ratio, well, you should know that that's the Bohr equation, and it calculates the amount of dead space to tidal volume. Normal values are less than 30%, and it utilizes your exhaled CO2, which is your PeCO2, and your PaCO2 in the calculation. So this is a formula that you'd want to know. You may be asked just to get the actual ratio, which is this side of the formula, where you take the PaCO2 minus the PeCO2 divided by 0.8, or you may be asked to solve for the actual ventilatory dead space, the VD. In that case, you would have the tidal volume and cross-multiply by what you get over here to get your VD. Assessment of the patient ventilator. Sometimes the exam asks you questions about ventilator assessment, and in regards to refractory hypoxemia, well, we all know that that's hypoxemia. That will not correct with increases in FiO2 alone. For example, a PaO2 of 50 on an FiO2 of 50%, while on the ventilator, that would be refractory because their PaO2 should be around 250. Take the 50%, multiply it by 5, that would give you your expected PaO2. So this person obviously has refractory hypoxemia, and the point here is that if we continue to increase the FiO2 with refractory hypoxemia, we'll have very little effect on the PaO2. So we need to do some recruitment, and recruitment means that we should add PEEP. So what do we do if we have refractory hypoxemia? Then we need to add PEEP, not increase the FiO2 further. Typically the exam will give you that option where you have the choice of either adding PEEP or increasing the FiO2. So when you see refractory hypoxemia, the correct answer would be to add the PEEP. Capnography is another popular question, knowledge base that you should be aware of. The normal range for your exhaled CO2 is between 35 and 45. In a percentage, that's around 4.5 to 6%. And when we have a capnograph device, which this one over here is a disposable capnograph device attached, we can actually determine levels of CO2, and we can equate that to breathing patterns. The EtCO2 less than 35 would basically mean that they're hyperventilating, and greater than 45 would mean that they're hypoventilating. The EasyCap device is not really used for that per se. It's primarily used for intubation and tube placement to make sure that your endotracheal tube is not in the esophagus and that it's in the trachea. And so it changes colors from purple to yellow when exposed to 4% carbon dioxide. And that's one of the things you want to remember, that for proper placement, it should change from purple to yellow. When it's in the yellow range, that means it's in the lungs and that you have CO2 exchanging. Assessment, extubation, stridor. When you have stridor following extubation is indicative of upper airway inflammation. And sometimes it can be severe, and sometimes it could result in the need for reintubation. It's very difficult to know for sure whether or not someone's going to have stridor. Sometimes it's one of those unknown things when you do extubate. So if a patient does exhibit marked stridor and retractions, then you typically have to intubate them. So this is again an assessment. The terms marked stridor and retractions, those are indicative of a high level of difficulty breathing. The person is really struggling. We're not just going to be able to increase their FiO2 at that point, because what it references is that the airway is pretty much closed and narrowed, and we're not even probably going to be able to give racemic epinephrine at that point because of the marked, which means that this person's in severe respiratory distress. So we would want to place them back on the ventilator, reintubate them would be the choice. Now, if they had just mild stridor following extubation, then you could provide the racemic epinephrine, because it may be just a small inflammation versus total obstruction. Just a review of pressure cycling. What does it mean? Pressure cycle means that pressure terminates inspiration. And some of the things that we have covered and you should be aware of is that if a pressure cycle machine will not cycle from inspiration to expiration, then the most likely cause is a leak. The gas will go to the path of least resistance, and so if you cannot, if the expiratory valve is either not shut or there's a leak, then you're not going to be able to go to exhalation, and the ventilator will continue to just blow gas. Remember that in a pressure ventilation, the volume is variable. So if you are giving an IPB treatment and the physician wants a certain volume, then really you need some kind of device that you can put on the expiratory end of the circuit, either a Wright's respirometer or some other type of pneumotac device that could measure volume. And that's referred to as volume-targeted IPB. A brief review of IE ratio. We know that the normal IE ratio is 1 to 2, and an IE ratio of 1 to 1 or less it should say, is considered an inverse eye ratio. We really don't want inverse eye ratios because they don't allow time for exhalation, and they could reduce our cardiac output, it could reduce our blood pressure. Sometimes we do use a strategy, or we used to use a strategy of inverse eye ratios to try to increase oxygenation. But keep in mind that inverse eye ratios can reduce the flow of blood to the heart and decrease cardiac output. Now, factors that affect your eye ratio, you should all be very familiar with this, is your tidal volume, your rate, and your flow rate, set rate and your flow rate. And if you're in a pressure mode, your eye time. So if you're setting in, let's say, pressure control, you'll be setting an eye time, how long you want that pressure to last. So if you need to reverse the eye ratio, then and that's what the question's asking you, then you need to consider either increasing your flow rate, decreasing your tidal volume, decreasing your set respiratory rate, or decreasing your eye time. Those are all those things will result in giving more time for expiration. And that's, again, an inverse eye ratio means you're not giving enough time for expiration. You're spending longer time in inspiration than expiration. Aerosol therapy, jet nebulizers, well, they typically need to be run at least 8 liters per minute. If you don't run them at least 8 liters per minute, then you don't have enough flow to power the jet. The higher the FiO2, the lower the total flow. So if you have them on 100% jet nebulizer, you know that there's no entrainment, so their total flow is whatever is set on the flow meter. So if you have it set on 15, that's all they're getting. And obviously that what will happen then is they can entrain gas, and they really won't get their FiO2. This is why we use a GIN, gas injection nebulizer. We can provide 100% FiO2 at about 40 liters per minute, thus reducing the amount of entrainment. Another factor is that since a jet nebulizer basically works off of Bernoulli's or Venturi's principle, that any water in the tubing will create back pressure. So as the gas hits the water, it causes back pressure on the jet, and therefore less room air is entrained. And so that will cause your FiO2 to go up. So you want to remember to drain the tubes, stupid, because a lot of times the questions have to do with an aerosol mask running and the FiO2 either being higher or what impact would the water have on the water in the tubing have on the delivered FiO2. So again, drain the tubes, stupid, is the bottom line. Look for those questions that relate to water in the tube and what impact it has on the delivered FiO2. Makes it go up. PEP devices, another popular area to ask questions about. They are, there's a picture of one right here, positive expiratory pressure devices, where what they do is they apply a back pressure to the airways to help facilitate mucus clearance. Common devices such as the acapella or the Flutter devices are on the market, and you should be aware of how the PEP actually works. It could ask you a technical question based on how it works, and it works by having the patient exhale through a restricted opening, creating a buildup of back pressure in the lungs. That pressure results in the expansion of small airways and opens side channels to get behind mucus and move secretions forward out to large airways where they can be coughed out. Basically, you're creating almost an intrinsic type of PEEP, which helps open those airways up and facilitate the movement of secretions. So when would you recommend PEP? Well, you'd recommend PEP for anybody who really needs mucus clearance. And we distinguish that from somebody who just has bronchospasm and needs a bronchodilator. If they need a bronchodilator, provide the bronchodilator. However, if they're having tract-retrained secretions, then you need to possibly order a PEP device. Airway, mouth-to-valve CPR. There are units that you will find in the hospital or out in the public arena where there's you can see this here, it is a mask, but it has a one-way valve that allows you to ventilate the person. And typically questions on the exam would relate to if you're not able to ventilate the person with such a device, what are part of the problems? Well, that relates to two things. Either the valve could be stuck, or the valve could be in a reverse position. Remember, this is a one-way valve, and you blow through this valve here. That ventilates them, and then the gas exhales out a port over here. So if the valve is reversed, obviously then the valve is going to open towards you, and that's not going to work. The valve has to open away from where you're blowing so that it can get in there. So if the valve is in the wrong position, you would not be able to ventilate the person. So sometimes the exam asks questions about the application of this one-way valve, and it's either could be stuck or it could be in a reverse position. You should know how to calculate airway resistance as well as compliance. Those are common questions that are asked on the ventilator, and sometimes they ask you what normal airway resistance is. So try to remember these numbers. Normal airway resistance is between 0.6 and 2.4 on a non-intubated patient, and about 5 centimeters on an intubated patient. So how do we calculate airway resistance? Well, we take the peak pressure minus the plateau pressure divided by the flow. Well, 9 times out of 10, they're going to give you those values. They're going to ask you to calculate the airway resistance, and you just need to remember this formula. Peak pressure minus the plateau pressure over the flow. However, there is one step that you have to remember. The flow must be in liters per second. Okay, if the flow is given in liters per minute, the very first thing that you have to do is divide the flow rate by 60. And most times they're going to give you the flow in liters per minute because that's what we set it up on a ventilator. So if it's 60 liters per minute, you divide it by 60 and you get 1 liter per second. So in this scenario, if our peak pressure was 27 and our plateau pressure was 23 and our flow was 50, well, if we divided 50 by 1 and subtracted these numbers, we would get an answer of about 3.3 centimeters for your airway resistance. So review this. Don't forget to step number 1, dividing the flow by 60 to get it in liters per second. So when do we change from volume ventilation to pressure ventilation? Typically there's questions that relate to that, and basically there are some benchmarks, and one of the benchmarks is any time that the peak airway pressure begins to reach or exceeds 50 centimeters. So if you're in the volume mode and you're starting to hit the peak airway pressure of, let's say, 50, or your pressure limit is set at 50, and you're hitting that, the person's hard to ventilate, they're not oxygenating. Obviously, we know that if we do not do something to limit the peak airway pressure, that will cause barotrauma, volume trauma, however you want to phrase it, and that can result in a pneumothorax. And anytime that we get that kind of trauma to the lungs, their survival rate goes down. The more we damage the lungs, the harder it is for us to repair the lungs. So at this point, when we start to see increasing peak airway pressures towards the 50 centimeter mark, that's when we want to move to some kind of pressure control or pressure regulated volume control, PRVC, and that would be a good choice. If the patient's having high airway pressures and oxygenation is poor, you have refractory hypoxemia on volume ventilation, then switching to pressure ventilation can help increase their oxygenation. And one of the ways it does that is when you go from volume ventilation to pressure ventilation, you will see that your mean airway pressure rises. So when we talk about increasing your O2, your PaO2, we know that one of the ways we can do that is to increase the FiO2. We can put them on PEEP, or we can increase their mean airway pressure, or we can put them on a plateau time. Plateau is the last thing that we would do, but the mean airway pressure strategy is a common strategy. So when we go from volume ventilation to pressure ventilation, we typically drive the mean airway pressure up a little bit, which can increase their oxygenation and their SATs a little bit. So we need to look for the scenario where peak pressures are starting to rise and hit 50. It's time to move into a pressure mode as compared to volume mode. Regulating pressure ventilation variables, well, these are principles that you should be aware of. If you're in pressure ventilation, then the delivered volume is directly related to the set pressure. We know that in pressure ventilation, pressure and volume are directly related. If I want a higher volume, then I need to increase my pressure. If I want to reduce my volume, then I need to reduce my pressure. So if a patient is retaining CO2 on the vent in pressure ventilation, and the exhaled tidal volume is less than what you would expect it to be, a minimum of 10 milliliters per kilogram, let's say, then you need to increase the pressure setting to increase the tidal volume. Another way to say this is if my blood gas comes back and I'm on pressure control and my blood gas is pH of 7.30 and my CO2 is 60 and my PaO2 is 50, and I'm on pressure control and I'm concerned about my CO2 is 60, how can I help blow off that CO2? Well, I need to increase my pressure. In a pressure mode, you need to increase the pressure. Volume is variable and dependent upon the pressure. Remember, to make sure that the minimum tidal volume for the boards is at least 10 milliliters per kilogram. I know that typically we're seeing in the hospital 6 milliliters per kilogram, 5 milliliters per kilogram, but it seems like the NBRC is lagging behind in terms of that. So we still would like to see the 10 milliliters per kilogram. So if somebody weighs 70 kilograms, then their tidal volume should be around 700. If their tidal volume is only 500, then that could be a reason why they're retaining carbon dioxide. So you need to increase the pressure to get that exhaled tidal volume up to what it should be. Again, this is kind of reinforcing assessing weaning and muscle weakness, that the NIF, should be at least 20 centimeters in order to wean or extubate. So if you don't have 20, then there's a good chance that you're not going to be able to, according to the books, that is, that you're not going to be able to wean or successfully extubate this person without them having to be reintubated. In real life, a lot of times we don't do the NIF. It's not a parameter that we actually use, but it's one you're tested on and one you need to know. We also use the forced vital capacity to assess muscle weakness in restrictive diseases such as myasthenia gravis, Guillain-Barré, and cervical injuries. So sometimes they're asking you to do spontaneous SVC, forced vital capacities, and your forced vital capacity, really, a normal FVC is going to be around at least 3 liters. However, when you have someone who has one of these restrictive processes, it's going to be considerably less. And when you're weaning somebody, if you can get a good FVC of 800 or even 900 cc's or 1,000, that's pretty good for someone who's on a ventilator who has an endotracheal tube in. Those are good values. If their FVC is only 350, that's not a good sign that they can take a deep breath and blow it out. The NIF is also referred to as the maximal inspiratory pressure. We covered that earlier. So don't forget that a drop or a rise in the level of electrolytes can affect muscle strength. You know that your potassium plays a role in muscles as well as magnesium. So you need to keep an eye out for that correlation. Is that electrolytes, muscle strength, weakness? They may want you to do an electrolyte level when someone comes in with muscle strength weakness, or you may need to choose which test would be good to monitor somebody for weak muscles. In the case of myasthenia gravis, you might want to do serial NIFs, you might want to do serial forced vital capacities, and electrolytes. Leaks in the ventilator circuit, well, you should all be pretty familiar with what determines or what things are indicative of a leak in a ventilator circuit. Typically, the number one thing when you have a leak in the ventilator circuit is you're going to get a drop in the peak airway pressure. So put those two together: leak, drop in the peak airway pressure. What are some of the common sources of leaks? Well, if you have a faulty expiratory valve, then the gas can escape out of that. You may have a leak at the endotracheal tube cuff. So the leak can either be in the circuit or the ventilator, or it could be at the patient. You always want to remember that. You want to look at the ventilator and the circuit, or it could be at the patient. In terms of the circuit, you could have a loose temperature probe, pressure lines could be loose, loose connections, anything like that. The endotracheal tube position is also a possibility, in that if the tube should come out and migrate to a point just above the cords, it's possible that the balloon is still inflated and the tip of the tube is just into the cords, and the person is actually getting ventilated, but they're not getting ventilated. So ET tube position, loose connections, leak at the endotracheal tube cuff, or faulty expiratory valve. Any one of these can result in ventilator leaks, as well as a person just popping off and being totally disconnected. Okay, this will be the last slide in this first series. Then we'll take a break and come back and continue the series. But Auto-PEEP or Intrinsic PEEP are things you should be aware of. It's also known as inadvertent PEEP. So obviously this is positive expiratory pressure that is in the airway that typically we don't know that it's there, or we don't have the ability to measure it under conventional means. And the question is, why would it be there? Well, those individuals that have loss of elastic recoil, such as COPD, emphysema, or severe air trapping, such as asthma, they would have this inherent tendency to have air trapped in their airways. Typically they can get air in, they can't get it out very well. So that's the Auto-PEEP. And since we can't really measure it per se without using some special techniques, we have to be very careful about how we apply PEEP to anyone who has an obstructive disease, COPD, emphysema, asthma. Now, certain ventilator settings can increase the level of Auto-PEEP, such as long inspiratory times. This is why we need to make sure that we give patients with emphysema, COPD, or asthma plenty of time to exhale. We have to be really careful about putting individuals like that on high respiratory rates, because when we put them on high respiratory rates to try to blow off their CO2, the adverse effect of that is more gas gets trapped in their airways. And when more gas gets trapped in their airways, they develop intrinsic PEEP. And you know that the side effect, or one of the problems with PEEP, is that it can cut down the blood flow to the lung, which can cut down your cardiac output. Inspiratory pause. If you put somebody in inspiratory pause, you're going to hold the gas in there longer. That could make Auto-PEEP worse. Low flow rates. The lower the flow rate, the longer the inspiratory time. A high set ventilator rate, which I already covered, and high tidal volumes. So you could have a question related to, or questions related to on your CRT or your registry exams that relate to what are some of the techniques, or what could you do to limit Auto-PEEP. And if you just review this list again, you'll see that, well, remove the inspiratory pause, have a higher flow rate, reduce the ventilator rate, reduce the tidal volume, give them more time for expiration and less time for inspiration. Those are all things that can help reduce Auto-PEEP. Okay, at this point we're going to take a break, and we'll come back with the second part of the review series.